Across the United States, survival rates for cardiac arrest, ACS, and stroke vary considerably from region to region. It's important that EMS and healthcare providers work together, not only to deliver patient care, but to strengthen the chain of survival for future cardiovascular patients. That starts with identifying the weak points in your system's chain of survival. Gathering data and measuring patient outcomes can identify areas that need improvement. The 2010 American Heart Association guidelines are very clear on this team approach. In order to deliver the highest quality patient care, there needs to be an integration of community, EMS, physician, and hospital resources. This applies acutely to the STEMI chain of survival. If community members are trained in recognizing the signs of cardiac arrest, EMS can be quickly mobilized for patient treatment. An out-of-hospital 12-lead ECG is essential to provide advance notification of a STEMI case to the receiving ED. This advance notification reduces the time from patient's onset of symptoms to reperfusion with PCI or fibrinolytic therapy. The goal is to treat the patient with reperfusion within 30 minutes of arrival to the ED. Because of the time-sensitive nature of the treatment, the guidelines recommend that all cardiac arrest patients be triaged to PCI centers or PCI-capable facilities. In patients suffering a stroke, integration of care is equally important. In these cases, time is brain. The sooner ischemic stroke patients within the appropriate time window can receive fibrinolytic therapy, the higher their rate of neurological survival. Much like patients with acute coronary syndrome, the chain of survival starts with bystanders recognizing the symptoms and activating the emergency response system. EMS providers evaluate the patient and alert the receiving hospital if they suspect a stroke. EMS providers should transport the patient to a stroke-prepared hospital if possible, where they offer best practices of comprehensive stroke care. If the diagnosis ultimately reveals an ischemic stroke, the hospital has 3 hours from the onset of symptoms to administer fibrinolytic therapy. The 2010 guidelines recommend that whenever possible, EMS should triage the stroke patient to a hospital where stroke care is offered. Patients experience improved survival rates, better functional outcomes, and quality of life when treated by a hospital specializing in stroke care. The American Heart Association recommends all eligible patients receive fibrinolytic therapy as soon as possible, within the first 3 hours from symptom onset. For a selected group of patients, the fibrinolytic treatment window has been extended from 3 to 4.5 hours. At the time the 2010 guidelines were released, this treatment window was not FDA approved, but it is recommended by the American Heart Association and the American Stroke Association Science Advisory. So let's recap the changes to the ACLS guidelines. The AHA simplified the adult cardiac arrest algorithm. The circular algorithm can help minimize interruptions in high-quality CPR or delays in defibrillation attempts during cardiac arrest while integrating IV access, drug delivery, advanced airway placement, and the treatment of underlying causes at strategic brief pauses. The AHA no longer recommends atropine for the treatment of PEA or asystole. The treatment of cardiac arrest no longer stops at ROSC. New post-cardiac arrest guidelines optimize cardiopulmonary function and vital organ perfusion, especially to the brain and heart. ACLS providers should consider hypothermia for every patient who remains comatose after ROSC because it is the only intervention that has been shown to improve neurological recovery. Quantitative waveform capnography can reliably confirm the placement of an ET tube and monitor CPR quality as well as ROSC. Finally, integrated systems of care should include community members, EMS, physicians, and hospitals in order to deliver the highest quality patient care. In the 5 decades since chest compressions were first attempted on a cardiac arrest patient, there have been significant improvements in the treatment of acute cardiovascular disease. There is much more work to be done. With the latest research pointing to new, quantifiable ways to improve patient outcomes, advanced providers have more tools than ever before to reduce death and disability caused by cardiovascular diseases and stroke.